All right, well, why don't we go ahead and get started? We got a pretty good group on here. For those of you who don't know me, my name is Nick Strasser. I work at Vanderbilt in Nashville, Tennessee. Jan Schukowski is at the University of Indiana in Indianapolis. I'm foot and ankle. Jan is foot and ankle and trauma. And, we're really honored to have the opportunity to present these webinars, with the goal of talking about some topics within foot and ankle surgery and gearing them towards those of you in medical sales. We definitely see y'all as being a part of the medical team, and as it comes around to patient care, we see that as being a very important role. And so the goal of this is just to try to talk through some of the cases that we see and discuss some of our approaches and why we do what we do when we get into surgery. So this is called indications. I mean, most of these are going to be ending up in the operating room, but just understanding why we're doing what we're doing, and then understanding why we're choosing the techniques and or instrumentation that we're choosing in some of these different cases. So we've been working through some different topics. Tonight is insertional Achilles tendinosis, and we'll go through some cases. And then I think just in terms of some housekeeping items, if there's questions that come up, feel free to ask questions in the chat. Hopefully everybody can see the chat there. I'll be kind of presenting the cases, and we'll be talking about some different topics that I've or different questions and thought processes on the different things that we're going through. And then Jan will kind of be managing the chat room, and we'll try to answer them kind of in real time, or at least as it kind of comes pertinent. All right, ready to get going then? All right, so this first patient we're going to talk about is a 62-year-old female with several years of heel pain, as may not be shocking. They're all going to have heel pain tonight. Past medical history has a little bit of hypertension, reasonably healthy, but a little bit bigger, BMI between 35, 36. Prior treatment is, by the time I saw her, had been immobilization in a boot. She took anti-inflammatory. She's used ice, compression, elevation. She's been to physical therapy, and she comes in to see me for gets referred for this heel pain. So this is what she looks like clinically. The symptomatic side is the left side. So, you can see here on the image, I don't know if you can see here, you can see that bump that's on that left side, that prominent spur right there. And this is her x-ray. And so she hurts in the back of the heel over here. So Jan, what do you think here? This is where her pain is.
Yeah, so great question. So this is a thing that, when we take these patients to the operating room, I've already had them exhaust conservative measures. I usually, I don't have a great reason, but usually it's about 6 months of therapy and non-operative management before even considering surgery for some of these patients. And that's because of, I'm really conservative with these, because if I used to do these with an open procedure. And so I've always been very concerned regarding wound healing problems. Now that I've gone to, and I think you're going to go over more of an MIS approach, I have not been more aggressive, but I've been, I would say, less worried about wound issues posteriorly. So when I see all this stuff in the back here, all that calcification, I'm always worried that's where their pain generator is.
When you talk about non-operative treatment, and I know we're going to get into a lot of operative discussion, but let's just talk about that real quickly. What kind of things are you sending them for? So physical therapy.
Yeah, and I usually tell them to take NSAIDs if they can, and then use a night splint. I think that can be helpful. So that correlates with their therapy. And then there's some patients here, and I don't know if there's any reps on the line who market this or use it. I will, for the patient that's not a great operative candidate, I have been saying them to a couple of my sports med partners that are non-op to consider 10x procedures on this.
Mm-hmm. So the couple things I'll go through is when I talk to them about physical therapy, I'll really try to drill into what kind of therapy they've been doing. When you talk about Achilles tendinosis, making sure that they've done eccentric exercises, I think is a key thing. And kind of what that consists of is almost this idea of lowering and loading the tendon gradually over time. This is a case in which if they're really inflamed, really flared up, I'll sometimes immobilize in a cast if they're really resistant to non-operative treatment. And I don't have any rationale, but I'll do 3 and 3, 3 in a cast, 3 weeks in a cast, 3 weeks in a boot, and then I'll get them back into some physical therapy for eccentrics just to try to start to gradually load it. But I think the eccentrics works better for the mid-substance Achilles tendon problems as opposed to the insertional Achilles problems. What do you think, Jan?
Yeah, no, I agree. And I love the cast treatment. I do many times incorporate that. If someone's having a lot of pain, I think a cast will quiet this down quite a bit, right?
Yeah.
If they're especially in some like acute process going on,
Yep.
I think that's almost maybe underutilized in some patients.
Yeah. Okay, what about role of injections?
Yeah, so I'm not a fan of injections. I know some people have tried, there's studies that tried PRP and stem cells, et cetera. None of those have panned out with any good long-term data.
Yeah, it seems like it's hit or miss. I'm not opposed to trying PRP, maybe around the same realm of 10x for me, but especially if they're really wanting to do that. But it seems like it's less effective than some of the other treatments you already mentioned. Anything else that you'd consider before you're taking this patient to the surgery?
I do get more imaging. I don't know if that's what you were talking about, but
what do you like to get?
I'll get an
Ultrasound?
I'll get an MRI for this type of patient, just to look at the tendon quality and if there's something I'm not ready for. So just like you did here, you could kind of see that inflammation here. Right
Yeah.
here. You can see my red circle, right?
Yep.
Yeah, so that's the inflammation that we're looking at, like in the operating room. For the reps on the phone call, this is what's called a sagittal MRI. So it's looking from the ankle from the side. And we're looking for that bright signal there. And that's inflammation along the back of the Achilles. And you can also see there's inflammation or tendinosis within the Achilles tendon as well here. And that's what we're looking for.
So the circle I would call kind of a little more anterior to that. We call that the retrocalcaneal bursa. That gets inflamed, and then the stripes that he drew, that's more of tendinosis, almost like this degeneration of the tendon. And you'll see a picture here in a second of kind of what that looks like in the operating room. What about role of like a CT scan, Jan?
Great question. That John Andrews just asked that. So unless I'm thinking there's something bony, like, I mean, obviously they have some calcification there. Yeah. But if I'm like worried about something, I have not gone to get CT scans. And then the other question was about extracorporeal shockwave therapy.
Shockwave, yeah. I think that can actually be pretty effective. Again, it seems like that's more effective for the mid-substance. So stuff that's a little bit higher up, not at the insertion. But again, not opposed to using it. The challenge with that and with like PRP is that it's usually an out-of-pocket expense. So it's hit or miss on whether or not it's an available resource.
Right, and I think it's one of those things though for patients. If you guys are using this or marketing it, the one way I always tell patients about it, if they ask me about it, we don't have it in our office, but it doesn't burn any bridges. So if a patient is kind of just like looking for options that are non-surgical, or maybe they're not the best surgical candidate, they might be really overweight, or they're, they don't have time to do surgery at that point in time because of work, et cetera. I think some of these other treatment modalities, they do play a role in the right patient.
Yeah. Anything else that you'd want to add, Jan?
No.
So treatment plan and approach. So if you're taking this patient to the operating room, I know you had mentioned like using an MIS approach in some of these cases. And this is one that I did open. That's how I felt like I needed to get into open it to get all of that intertendinous calcification. And maybe that's debatable, but at the time of this case, that was my feeling. So that's how I approached it. How are you approaching these? If you do an open approach, I know you had mentioned that concern for wound healing problems. What's your strategy to access the tendon and the bony issues?
So I've done it two ways, and you know, I've gone back and forth a little bit when I've done them open, whether to do a direct midline, straight midline, you know, and split the tendon, or like if I do an open Achilles tendon repair, go more slightly cheat medial because of the blood supply.
Yeah.
So I've done both of those. I think the easiest is just to go straight midline. I mean, that's just, I mean, it's the easiest dissection you could probably do in orthopedics.
Yeah. So, and I'm just going to take a step back. I kind of jumped into it, but when it comes to an open approach, at least what I'm trying to treat when I'm getting into an open approach is, one is to treat the tendinosis. So getting rid of all that degenerative tendon. Two, get rid of all the calcifications. And then three is address the bony deformity on the calcaneus to kind of smooth that out. So I think of it as three things that I'm trying to treat. And then obviously to do all that, you have to take the tendon off when you're doing this in a traditional open approach. And so then that's where some of these repairs get into, and we'll kind of see a couple different examples here as I get into the approach. So I used a central midline tendon splitting approach, which I think is probably one of the more common approaches right now. Don't you think, Jan, when you hear people talk about this?
Yeah, I think this is the more traditional approach, and definitely it's the workhorse for this.
Yeah. And, you know, it's interesting. When I did my fellowship, we would use a lot of posterolateral approaches, which is a great way. And I'll show a case a little bit later of that. But this is kind of what I think I've migrated to. I think especially with the advent of some technology, such as a double row repair, taking a playbook out of our shoulder surgeon colleagues' approach to like the rotator cuff, this just gives you a really easy access at the tendon. So I use a tendon, I split the tendon in this case. Now, if you go straight midline, do you ever just take the tendon off in one big flap where instead of splitting it, but just lift it off and then work underneath it? Or do you always splitting the tendon?
I'm always, I would say, 99% of the time splitting the tendon.
Yeah. That's what I've been doing as well. I heard somebody describe just taking the tendon off one big sleeve, almost like a sleeve avulsion if you're doing a primary repair. And that certainly makes a lot of sense to me. But this is what I've done the lion's share of the time. So hopefully, I don't know if my mouse is showing up, but you can kind of see in the middle, there's a split on the image on the left. And then on the image on the right, you can see where I'm using my scalpel to get into that tendinopathy, the tendon that's just really degenerative, which is usually on the ventral or anterior surface, right next to the calcaneus. It's where you get almost all that compression from the calcaneal deformity onto that tendon. So I'm taking a knife and I try to, as soon as I split the tendon, I try to do that debridement at that time. I don't know when you're doing it, if you're developing flaps or when you're doing that debridement.
No, at the same time. I mean, just like you said, just through this approach, I mean, you see it right away. So there's not a big, there's no, it's very easy to notice it, and you can kind of see the normal tendon. It's hard to see on this image, but you'll see the normal tendon, and then you'll see fibers that just look like very glossy white fibers. And those are that's the tendinosis or the scarred tissue.
Yeah. I've heard people describe it as codfish appearance. So it's just this. So this another view here, kind of from the image on the left here from the side. You can see, where all of this stuff here, just all this stuff is just very degenerative looking, irregular appearing tendon. And so all of that has to go when you do that approach.
So I got a question for you, Nick, right here, just looking at that last x-ray. So you've resected the bone, you've debrided the tendon. Where can you point exactly with your mouse where you want to now reattach that tendon?
Well, so that's a good question. I'm going to make a couple of statements before I get to that. Okay. So one is, I'm showing the saw doing the resection of the bony deformity here. And what I'm pointing out here on this arrow is something that was pointed out by one of my mentors, is making sure you get all the way down to that insertional ridge. So when it comes to where I'm making this, and I'll be honest, I'm oftentimes not getting an X-ray, is I will do kind of a 2-row, and I will put one right here as my proximal row. And then the other one will get a little bit farther down, probably right in here.
Yeah, because I know some people are using X-ray, and that's where, like, I think with the reps, why do you use the double row technique?
I like it because it gives me a broader footprint and it avoids the knots in that area. Because that was one of the challenges I had, because I'm just old enough to remember it before the double row technique was out. I think the speed bridge kind of brought that into, it popularized it. So I was using just 2 anchors, tying a knot, and the knot would become an issue. So that's why I'll use that double row technique. And I feel like I can rehab them, or it seems like we can rehab them a little bit faster with that approach as well.
Yeah,
How are you repairing them?
I do the double row too, and I use a speed bridge. I don't get paid by Arthrex, but I think for anybody on the call, if you have a similar system or can make it, right? I mean, they just make it easy with a kit. I mean, that's what it is. I have no, I don't think their anchors are necessarily better than others, when I've used anchors in other areas of the body. But it's to make it easy and knotless. So whatever system, I agree with you there. If you can make it knotless and make it reproducible and easy to do, I think people will use it. And I know other companies have now similar kits, is what I've been told. I have not researched it, but for those on the call, I mean, just making it easy for the surgeon here and reproducible, I think are keys to why we would choose one implanter over the other. There's no I've not seen any strength difference between a double row of one company versus a double row of another company.
Yeah, but I agree that the knotless really is a big difference. It's funny though, talking to some of my senior partners, they said where they talk about how they just would cut it and then just basically suture it back together and not really do anything, and then cast them for a while. And they can heal. And it's amazing too. The other thing that's amazing is I always check a Thompson test at the completion of the debridement before I do any repair. And oftentimes it's still intact. There's enough fibers on the side that it's still intact. And then the other thing I'm going to make a point of saying is that the debridement of the bone is very important. And so this is one thing that I use is that power rasp. Remember, the back of the heel, the back of the calcaneus is crescenteric. It's got rounded edges, the anatomic normal heel. And so if you cut it completely flat and you don't round the edges down, they will get pain on the edge where the tendon attaches. So I do think that part is very important. So I'll use this to get medial and lateral and make sure I have it all rounded out.
Do you know who makes it? I've never used that power rasp. I'll use a rasp by hand, and it's just it's not very I don't know.
The rasp by hand is not great. I can look up the part number on this and figure it out.
Yeah, I wonder who makes that, because that's another thing for those on the call, having something like that available. I'm sure that that I think that would be very helpful in the operating room. For the surgeon and explain what the advantages are, because I think it would be a more even surface that you would get, right? I mean, a more consistent rasp, so to speak.
Yep. Yeah, you could really get it nice and really fine tune the edges with this. So I use this a lot. Questions: in situations where the Achilles is off the bone due to the Haglund's resection, are you still doing a knotless technique? I'm assuming you're doing the same, Jan.
Yes, I think the knotless technique, anything without I mean, you don't want any prominence back there. You're worried about soft tissue. People can feel those knots. Fiber wire doesn't go away. So yeah, knotless is the key there.
Yep. All right. So the bone, I think the bony resection is very important. That's something that's been hammered home to me. And so I definitely spend a lot of time addressing that. So this is, This is an example of a double row repair. This is kind of what Jan was referring to. That this is from a couple of years ago, but this is using I think this situation I was using the Stryker Iconics anchors, and it's a soft or all suture anchor approximately. I believe these are 2 millimeter tapes, and then a 1.2 if I remember correctly. And I liked it because a little bit thicker tape that got me a nice broad surface area, and then brought down to a couple of Tino screws. I think those are 475 tenodesis screws into the for my second row. I used, in this situation, I think I used the smaller tapes to kind of initially set my tension. So I would tie a knot there. But the nice thing about the suture tape is it lays so flat even when you tie a knot, that I would do that, and then I would pull that down to the screw, and that kind of laid it nice and flat. Any comments on this, Jan?
No, not at all. I do it maybe fairly similar to this, and so forth. Question though, how are you sewing? Because you split the tendon in half here.
Yeah.
The image on the left. How are you sewing it back together?
So I will do that. I'll put the anchors in first, and then I'll take just vicryl and suture that back to just a buried vicryl, O-vicryl, just to get everything back together so I can make that nice firm layer. And then I'll do the second row after that.
Great.
This is another technique I've used. This is a little more recent picture here. This is using, this is an Arthrex anchors here. And in this case here, I'm using a knotless technique. So this has tapes proximal that I've run out a little bit more proximal. And then these knotless sutures here are actually going back and forth to each other. So I'm taking the one knotless to the other anchor and pulling them through, and I'm creating basically a bridge to bring the tapes over the top. And then taking that down to 475 Tino or swivel locks in my second row. And that kind of gives this ripstop effect in this case here. Same thing, I repaired the split first, and then I brought those through and created that kind of bridge effect. I really like that. That's been my that's what I've been using more recently. But you use whatever system you're comfortable with and what you have available. But I think that's some of the rationale for why we're choosing some of the systems that we're using. That there's it's a robust repair, it's low profile, it doesn't seem to cause an issue for the patients.
Yeah, so there's a question from Eric. How challenging is it to really differentiate between calcification, bursitis, and Hageland's? I'll let you take that for the first crack at that one. So
sometimes it can be pretty challenging to see the difference. I think probably, if anything, the most challenging is to see the difference between normal tendon and tendon that has tendinopathy. The calcifications, usually you can see and you can find just by feeling in that. So it's a combination of looking and feeling, and then making sure that you're getting an x-ray and you can see that the calcification's gone. The bursitis looks more fatty tissue, so that's less of an issue. And maybe that's a good question, Jan. How much bursa are you resecting? I've heard different opinions on how you should approach that.
Yeah, I just resect what's there.
That's kind of how I approach it.
I'm a simple person.
Okay. And then the Hageland's, I use a lot of x-ray for the heel, because I know that's what I'm going to see. If there's any questions on when they come back to the clinic, if they're having any pain, I use fluoro to really fine tune it. And then I'll use that power rasp to really kind of smooth that edge of that calcaneus down to a nice smooth edge. And I'm feeling and looking on x-ray to make sure that's nice and smooth. I probably spend the most time doing that, to be quite honest.
Yeah, I agree. And the thing is, I don't know how symptomatic a patient is from if you leave any residual bone there. I feel like they're when they see the x-ray though in clinic, and you didn't, or the fluoro shot, and you left some bone, they feel like they're still going to have pain.
Yeah. Just remove all doubt.
Just have the patient rather than the issue.
Have a pretty looking x-ray, nice and smooth, looks like it's nice and well rounded, and it's amazing how much that helps. All right. So what about your post-op rehab protocol?
Yeah, I have on this traditional repair, I would say, or with the Haglund's resection, I'm very slow, and a lot of the times it's usually because the patients tend to be overweight, right? I find that really, like, I would say thin patients do not get this issue as often. So I go really slow. I start them, they're non-weight bearing for the first 2 weeks while they're in a splint. I then transition them now to a cam boot with wedges and make them weight bearing as tolerated at that time with the use of with crutches or a walker. And then I begin a slow rehab protocol with them just to make sure that they don't tear off the tendon and so forth. I knock on wood, have not had it happen. But maybe that's because I'm ultra conservative here.
Yeah, I've gone back and forth a little bit, and some of it depends on the patient and their compliance. I'm probably immobilized in a splint and or cast for until about 4 weeks, and then to a boot, and let them start on physical therapy. And for me, it keeps it relatively simple when I'm explaining what they can do and when. So a month of immobilization in a splint or cast, a month in a boot, and then wean out of the boot at 8 weeks. And I usually tell them by 3 months they should be into a regular shoe and starting to resume activities. But I'll tell them it's a year until they stop. That heel can be sore and sensitive. It's probably about 12 months before that goes away.
Yeah, quick question here. So we have from John, and I'll take this since you got the last question, but is the calcification painful, the spur, the bursitis, and the Haglund's? And so John, it can be difficult sometimes. It's a little combination of all the above. Just because someone has a spur back there or Haglund's doesn't mean it'll be painful. Most patients actually that you treat their symptoms will improve with conservative management. So the stretching, the therapy, sometimes immobilization. So it's a combination of all the above. But just because they have a spur, I get referred many patients because they have a bone spur back there. And they got x-rays for some other reason, or maybe they had plantar fasciitis and there was a spur back in the back of the heel, and they come and see me thinking that they need, somebody kind of told them it had to be removed. So this is where, like, physical examination and history are very important for these patients.
Yeah, it's a good question too. What I like about it is it gets into the definition of some of these different things, because I don't think it's always that clear. It's actually taken me a long time to make sure I understand which part is symptomatic. So, I think to his point of the question, like the Haglund's is kind of the bony deformity off the heel, that posterior superior ledge of bone. And then the tendinosis is, that was referred to before, the insertional and the non-insertional. So you kind of can classify those based off of anatomic origin. And then the bursa can be painful, and it can be a deep bursa and the superficial bursa. So if you have somebody, usually a little different scenario, but that comes in that just have a Haglund's prominence, or what we would refer to sometimes as a pump bump, they can get more just of a superficial bursitis because of the rubbing in their shoe. And that's sometimes where you see them come in with like a shoe cutout or something like that. So there's the definition of what is actually symptomatic can be a little bit challenging to sort out. And I don't always think is very, very well understood.